So the 6th area we can start our implant, but we have to tilt it
Medially.
Yes, medially.
Like you do in all on 4.
Yes, exactly. It's also all on 4 extended.
Yes, all on 6.
Yes. See here there are 2 options.
Yes.
Either you can. So from 6 we can start the implant, which is a luxury.
Yes.
If you start the implant from 6, the advantage is there is no cantilever.
Yes.
Okay. Even from 5 you can start the implant, but 1 tooth you have to give cantilever. So, but from 6 itself you have got good bone. You are tilting 2 angulations. One is mesially, because if you go straight you will enter the sinus about 15 degree mesially, and also palatally also. Here there are 2. Here there are 2 variations we can do. However, we will do alveoplasty here. We can do drill like this, mid-crestal. This is called mid-crestal. Or we can start the drilling from the palatal crestal and do the drilling till here. More longer, right? More longer implant. And there is one more drilling technique, parallel approach. You start the drilling entirely out of the alveolus. Go like this. But these states will be exposed. Okay. So 3 kind of drilling techniques. One is mid-crestal. Second is palatal crestal. This is palatal approach. Alveolar bypass. So if you start from here, your angulation is like this angulation is like this angulation is like this. Okay. If there is a good buccolingual width, you can start mid-crestal. If it is thinner, you have to think about starting from here or starting from here. So now we will check. This is a 4 mm now. We will check mid-crestal. It looks fine only. Okay. The challenge with this is the abutment will be buccally placed. So if you place the implant like this from the palatal crest straight away like this, the abutment will come here, which is a more favorable position. So this we can decide during the surgery. So one implant from the 6th region tilted palatally and mesially. The other implant we can place it in the first premolar straight away. See, in this first premolar there is no much concavity. The concavity is more on the, I don't know, it may be due to the ortho issue. Many cases they are ortho candidates. So even if you drill through the apex here blindly, you will enter outside dehiscence. So anyhow, we will be doing lot of alveoplasty because the patient is vertical maxillary excess like this. Almost 16 mm implant we can use. We will see the 3 ways. Now another implant we can place in the, and also understand we cannot place implant in the 1-1 area. Okay. If you place the implant in the 1-1 area, you will be very close to the incisive canal. Okay. Be too close. So always we place the implant in between 1-1 and 1-2. So this is the apex, right? Through the apex, if you drill, the implant will be close to the labial bone. Okay. So start the drilling palatally. Go like this. Okay. So either you can do the drilling like this, or start the drilling from here and do like this. Palatal approach. Okay. In the palatal approach, the abutment will come in a more favorable position because the tooth are already proclined. We want to push them back. Okay. So there are 2 approaches we can do. This approach is much better. Okay. Of course, we'll be doing labial till here. So implant from here to here. Okay. So what could be the length? Like this. From the palate. Around 13 or 14. And it is well away from the nasopalatal canal also. Yeah, you can see now it is close to the canal, even though it is between 1 and 2. So how to know the canal? Just open it, dissect the canal, and you can see the canal and you can do it. To 1 to 2 area. You can see there is a bone defect here actually. Periodontal bone defect. So we will be doing labiaplasty maybe either till here, if not till here. So this kind of cases,
BCS.
instead of BCS, you can do the palatal approach. That is more safer. Like this.
Okay.
Like this. So this is the canal. Yeah. Another implant in the 6 area. From the 6, if you place straight, you are into the sinus, right? So what you do is you have to tilt around 15 to 20 degrees in front. So you can tilt like this from the mid crestal, or start from the palatal crest, or entirely palatal approach technique also we can do. But I feel from the palatal crest we can drill parallel to the labial plate. Labial surface is our landmark. Just drill parallel to it, like how we did for the last patient, the nasomaxillary. So expose this fully. So keep an eye on this. Start from drilling here and make sure it is parallel to the labial surface. Even if you do labiaplasty like this, you can place a 16 mm implant. So the length can be determined by from CBC? No, because how much labiaplasty we don't know. Where the drill drop will happen, it may vary. So the length will be decided by doing surgery. So if you see here, this 6 we have tilted very little, but this 6 we have tilted very much. So if you place one implant, this may interfere with this one. So even this 5 implant is enough if you are going for a bar. That is more than enough.
Bar.
Okay.
Or multi-unit and bars.
Huh?
Or
multi-unit and bar. Multi-unit bar. If you are placing single piece implant, definitely you need more. You need to add better to extra.
So even if we place pterygoid, we don't store 7 and 8. In full mouth rehabs.
Yes.
Even if we place pterygoid, we don't replace 7 and 8. We still
in provisional we don't give 7.
Okay.
But in final process we give 7. So that is the advantage of placing pterygoid. You can give 7. But if your last implant is 6, you can give 7.
Okay.
If your last implant is 5, you can give 6, but not 7. 7 is not necessary.
One can deliver is easy.
Even conventional, they are placing implant from 4.
Yes.
And they are giving 2 tooth cantilever in final process, not in the provisional process. But they are quite risky.
Yes.
2 tooth cantilever. So up to 10 to 12 mm cantilever is okay.
Yes. Palomalo concept.
Yes. That too, if you are using bar, cantilever is successful. But you are using cement retained, cantilever is totally should be avoided. No cantilever if you are using for going for cement retained bezel, no cantilever. So that is the advantage of using titanium bar and multi-unit process. Cantilever is allowed, and inter-implant distance can be more. Fewer implants you can place. These are the 3 advantages. You can restore FMR with fewer.
But so bar cost goes almost about 35,000.
Okay.
मतलब lab.
Even the cobalt probe.
Yes, even cobalt probe goes 20,000.
Okay.
मतलब if you are doing FMR मतलब using titanium bar or cobalt probe processes, उसके ऊपर मतलब ये 35,000 40,000 for the prosthetic part.
Okay.
Lab charges. Lab charges. Then implant almost 30,000-40,000.
Yeah, understand.
The 1 hour almost cost 80,000
For the lab itself.
for implant and lab.
See, that is why I am telling you.
Full mouth should be मतलब at least 2.5 for per hour मतलब at least 4 to 5 range मतलब.
So going for